Good morning, everybody. Welcome to Thessaloniki, welcome to the conference, and welcome to this panel. This panel is named Quality Standards for Prevention, Challenges in Latin America and the Caribbean. My name is Diana Lesme. I'm from Universidad Católica of Asunción, Paraguay, Catholic University, and I have the honor to moderate this panel with this set of experts and friends and colleagues that I appreciate very much. So thank you for being here. We will have just a few reminders of the methodology. We're going to be speaking in a certain order. Each one of the presenters have 12 minutes sharply. We'll be reminding the time. I will be presenting them first. I have a long CV that I will present to you. Just a few reminders, highlights of their CVs. And then we're going to be starting, and questions are to be, I will ask that you write your questions, and then at the end of the three presentations, we're going to have a time for discussions, okay? Just to present the panel, what is that we're going to be talking about here? We're currently facing in our region the introduction of different approaches to substance use prevention, such as the Iceland model, the UPC curriculum-based models, evidence-based intervention focusing on specific risks and protective factors, and information-focused interventions. The last one mentioned is the most common in the region because it meets the need of a wide coverage intervention, which are an indicator requested by governments in most countries, regardless of the evaluation of its impact on the target population. The speakers of this panel will present experiences in research and academic programs in prevention of universities that follow quality standards. The experiences presented guide policymakers and contribute to adjusting the ongoing presentation to be more effective and generate the needed evidence to make information-based decisions in drug demand reductions. Furthermore, it would allow the academy to approach government decision makers, which is very needed, and possibly articulate efforts and science-informed decisions between these two areas. It is my pleasure to present, here on my right, Dr. Fernando Salazar Silva. He's from the Cayetano Heredia Peruvian University in Peru. And I will present briefly Fernando. He's a principal professor at the Cayetano Heredia Peruvian University. He's worked in drug demand reduction starting in the mid-90s. So he has a long way. He has a lot to share, that means. Based on his background in epidemiology, Fernando started his involvement with substance use and people's well-being when he directed two national studies for the VIDA, which is the National Secretariat of Peru, that deals with drug demand reduction. His concerns with a clear link between substance use and the deterioration of society and people's well-being led him to look for means to intervene actively in this problem. After several years of work, Fernando considers a milestone in his career the landing of a multi-component, multi-level school prevention intervention that show its effectiveness in substance prevention. This was reached thanks to having conducted the project to evaluate the effects of the universal prevention curriculum for schools on substance use among Peruvian adolescents in the past 5 years. He's very happy now because he found a way to deal with substance use initiation and progression in alliance with clients and other prevention advocates like him. Welcome, Fernando.
Hello. Okay. Thank you so much, Diana, for the presentation. I didn't know that much about myself, but it looks like that I had a lot of fun in this area. And actually, I had. And just before presenting myself, I have to say that I'm wearing a shirt from Paraguay. I'm Peruvian, but I'm wearing a Paraguayan shirt. Because at this moment, what I'm going to tell you about this kind of program or project or intervention is going to be applied nationwide in Paraguay. So we are going to have the honor of putting all of this stuff that we are going to talk in a really very interesting setting. So I will talk about a very little few things in this area, and focusing in the quality standards of our intervention. And I will highlight the standard rather than going into the details of the intervention, even in the details of the monitoring and evaluation or the results. So to start this, I'm going to talk about the problem. The problem of substance use in school settings for kids and adolescents is the substance use by itself. Kids and adolescents that shouldn't take any psychoactive substance are taking it. And we cannot accept in any level of or proportion of the population that kind of figure, because everybody I think in this room knows the kid is still in a stage of development in which his brain is not fully developed. So there are some conductual and physical things that are going to be affected. Why am I highlighting this thing? Because there are many prevention interventions in school settings that directed, and that's right, is good, the intervention, let's say, for small kids, just to develop some social, emotional, or life skills that are okay. It's the best thing that we can do for those ages. But some schools consider that they are doing substance use prevention just with that only intervention. If we don't focus our sight in the problem that we are dealing with, we are going to lose our direction. And that is one of the key things that I have to put in my interventions, that our outcome is behavioral and effective changes in substance use, right? And that's it, the problem. Another problem is what Diana was reading in the presentation, is the usual practice in school prevention. Would you please raise their hands, those that know or have seen in schools to people from NGOs, police, even some other stakeholders going to school to deliver some speech? All right. If we can do that, many people is doing that, and many countries in the region are doing that as the only intervention, going to deliver information. And that's a very big issue, even for SICAD, the coordinator of the regional ICU meeting of the ICU DDR. Because when they have their multilateral mechanism of evaluation, they have to report or gather information about prevention programs. And the nation that have a school prevention model based on information, it's okay in the report. But in the real life, that thing is not going to work, because it's not enough. The other thing is that most of the intervention in school settings are usually delivered by untrained persons. And we are saying two things. The quality standards for prevention that from UNODC says prevention cannot be based only in information. And other quality standards, people that goes to prevent in the schools must be trained. And finally, A single activity is not adapted to the school curricula. Even a single activity is not adapted as in the school curricula. What I want to express with this, we have even multi-component intervention that can go to the schools, and we appear in the school, and we put the program in the schools, without taking into account that the school has its own curricula, its own structure. So we are invading the school, and one of the international standards says one intervention must be part of a larger intervention. If we understand the school prevention is education. So one of the things that we have to do is to coordinate the areas of school prevention with the areas of the school curriculum. And later I will say why is this very important. So, I'm just in the second slide, and there are many problems with this, with the international standard. Now, on the other hand, what we know about prevention? At this moment, we have three very strong areas for prevention. Prevention science, the international quality standards, and the implementation science. I'm very glad this morning learning that one of my best friends in this area is making her doctorate in implementation science. Wow. And what is each of these areas telling us for prevention? Prevention science basically is saying two very important things. Substance use is part of a developmental process in persons. So, prevention cannot be only one. Have to go through all the developmental stages of the kids. And the other really very strong thing that I use for prevention in schools, coming from the prevention science, is the etiological model. That put all together two very big and strong theories. The theory of the ecological systems and the theory of the behavioral change.
Fernando?
5 minutes? Okay, I will go faster. So prevention science is saying you cannot go only in one direction. You have to go to the person and to the environments, macro and micro environments. International standard is saying many of these things, but basically you have to choose one of the interventions that has been proven and has evidence of efficacy. And implementation science is telling us you have to go in this order. Needs and resources, assessment, planning, implementation, monitoring and evaluation, and communication. And other things that I will present very briefly because Diana showed me now 3 minutes. So with all of this thing, we developed a logic model for the intervention that put all together. I will not show the details of this. But when the logic model is followed, the first thing is training of implementers and community persuasion. And community persuasion is one of the criteria that is being lost all the time. We think, everybody in the room think that the most important thing that we have to do is prevention or treatment. But the people are thinking in different things. And we have to persuade them to enter into prevention. Then continue with the training. We have to train people to building teams for a comprehensive school-based prevention, for following all the cycle of implementation. If we don't have the structure for prevention, this team for prevention, the prevention will be a flower of one day. Will be lost in the space later. Next, once we have this resources assessment, all the previous, the plots, the teams for prevention, we have to start with developing a school policy that is the first step in school prevention. And after the school policy, we have to develop a school climate. And when those two school policy and school climate are in place, then we can start with school curricula. Why? Because school policy and school climate are working in the environment, in a very good environment and positive environment for teaching the kids whatever, even the school prevention curricula. If those conditions for learning are not in place, everything that you did after is going to be the same as you invade a school and don't prepare the school and deliver speeches. And we can see in many places very good developed school prevention curricula that are not having effect. After that, we can work in positive classroom climate, microclimate, and strongly work in interactive teaching skills. That is also in the international standard as one of the key issues for prevention. So many little things. 30 seconds. One. Okay, don't make me nervous. I'm going to finish this in 45
We'll give you one extra.
Then one of the other things that we must do is monitoring, evaluation, and technical assistance. This is the quality assurance of all the intervention. When we have all of those things, we can show results. And here remember the first or second slide is prevention of substance use. So the result is directed to show result in substance use, no intermediates as the final result. Is substance use. After that, I just have to remember that the main issue in school prevention is this integration of the intervention with the school curriculum. So many very little pieces of quality standard that are lost in most of the interventions. Did I hold my time? All
You
right,
are
thank you so
perfect.
much.
12 minutes sharp. Thank you.
All right, hope you understand.
Thank you, Fernando, for being so good and complying to time. Thank you. We will have more time for questions after. Now I would like to present my dear friend and colleague, Dr. Silvia Morales-Chainé. Silvia has been the psychology faculty of the Autonomous National University of Mexico, professor since 1999. She has received a psychology doctorate in psychology with a concentration in experimental analysis of behavior and an MD specializing in addiction psychology from the same university. She has worked in the Teaching and Services Center coordination, providing counseling services to the college community and general population to promote mental health and prevent addictions. She's recognized as a national system researcher, part of the academic performance program of the UNAM University. She also has professional experience working as a child's behavioral analyst. She teaches learning and adaptive behavior, addiction psychology, and methodological and theoretical research skills courses. Along with her teaching, she graduates bachelor, master, and doctoral students while they practice their knowledge and skills in community service. Through her work, she has participated in bi-national conference and the reduction of drug demand and mental health gap reduction. Her research is mainly centered on impulsive choices. Notably, she studies temporally, probabilistic, and effort discounting for losses and gains with children and adolescents suffering from behavioral problems. Recently, she has developed a research project about mental health conditions related to COVID-19 pandemic contexts. Silvia has extensive scientific production with several recent publications. Welcome, Silvia. The floor is yours.
Thank you very much. I want to thank Diana, Fernando, Andreas, of course, Alfonso, for the invitation and considering having us in this panel. Thank you very much. And I'm going to talk briefly about the brief intervention to selective and indicative prevention in mental health and addictions. This is a job we were doing during the pandemic. Then I hope you enjoy what we have been doing. along these 4 years. As you know, well, an increase in drug use and mental health problems has been reported in low and middle income countries as Mexico. Then United Nations also show how in Mexico the use drugs has been rising, as well as mental health problems that are important for our country. In Mexico especially, we have a study that shows us that almost 90% of Mexicans suffer from harm, alcohol or drug use. Many of them suffer from depression, anxiety, post-traumatic stress, and also they were suffering from suicide thoughts and behaviors, chronic pain, emotional symptoms, thought plans, acts, and self-harm during the COVID-19 pandemic. We found these problems. Then we also have this context. In this context, we have the intervention gap that is still wide in Mexico. In Mexico, we have 3 professionals per 100,000 Mexicans, and in addition, we have very few professionals that can work in the country. The present study that we are showing you, it's the one that describes the evidence-based brief intervention implemented to face alcohol and other drug use and mental health risks during the COVID-19 pandemic in Mexico. We have been evaluating mental health risks and drivers of change, set behavioral goals, collaborated on developing action plans, and followed up on achieving these life goals. We quickly intervene and economically explore behavior change, helping to address mental and physical health risk. We also add to observable phenomena and pragmatical conditions, focusing on the repetitive behavioral sequences that promote mental health in our population. We want to show you that we have been working through a programmed algorithm into the action program clinical handbook to reduce the primary health care. This is what PAHOR has recommended to work in primary care and to close the gap in mental health and substance use disorders. As you can see, we program algorithms that give feedback based on a triage, psychological triage, and these algorithms also give psychoeducational modeling, self-care, for example, or relaxation techniques, and skills teaching by model and other apps. It's based on consent to use the data for epidemiological issues and to accept psychological care in this primary level. Our results are important, and the ones I wanted to share with you today, it's these important things that we have been founding. First of all, we have been able to reduce the gap in the treatment, in the primary care treatment. And as you can see, when we start, we have just 4% of the participants seeking for help. In 2023, 76% of the participants were accepting this treatment. How we can explain this reducing gap? As you can see, the work of promoters at the community level is the way we can reduce this gap. As you can see, when a promoter, mainly woman, is helping in the community, almost 8 out of 10 participants seek for help in our primary care level. In these 3 years, we have been working with these different levels that PAHO has recommended, and as you can see, more than 59,000 participants received informal community care, more than 3,000 primary care services, 400, even more than 400, received specialized secondary mental health services, and more than 1,000 specialized mental health services. As you can see, they were mainly symptoms that people is asking for help are those about anxiety. And the second place is alcohol and drug use in our community. We have been able to, in these brief interventions, implementation, to see which professional behavior we can see that is helping the people to get better with mental health and drug use risks. And as you can see, those behaviors, we have been observing more than 7,000 behaviors. 2,000 are about essential care behaviors. More than 2,000, almost 3,000 behaviors has to be with assessment skills. And more than 2,000 behaviors has to be with managing the mental health. Several behaviors of the professional has to do with solving questions, summarizing, active listening, for example. In assessment has to do with physical problems, assessing physical problems. And in the management, we have been seeing behaviors that has to do with stress coping, nutrition, physical activity, healthy sleeping, etc. These professional behaviors have helped us to find these results. We establish operational goals and intervention plans with the beneficiaries' participation, and they have designed the elements for well-being recovery. As you can see, almost 8 out of 10 participants have already recovered their health, and 12,800 interrupted their treatment. Several procedures impacted treatment goals. The main procedures has to do with functional analysis, decisional balance, goal establishment, skill training, and follow-up. Then brief intervention that we have been working with in the community are based on scientific evidence and help to reduce risk from alcohol or drug use and mental health conditions at this community level. These results also show us that participants have reported an increased skills about communication, decision making, social interaction, stress coping, sadness management, anxiety, and family interaction skills. Then what can we conclude? That Mexican skills to cope with mental health and drug uses damages increased at the end of these brief interventions. As I was telling you, 77% of participants accomplished their goals and were successfully discharged from treatment. It means that almost 8 out of 10 beneficiaries interrupt their mental health or alcohol or drug use. However, and despite this, we must solve intervention barriers with approximately 2 out of 10 Mexicans that interrupt the program. Concerning satisfaction, 100% of those who complete their treatments reported that the service received was helpful, and almost 94% say that it helped to deal with their problems better, and they were very satisfied. Another conclusion has to do with that we have described optimal mix of services for mental health. As you can see, 100% of the participants received informal community health tools. 67 were those that were having these interventions in primary care, almost 9% in secondary care, and 24% in specialized third level. Then participants accepted treatment because symptoms of anxiety, but mainly for alcohol and drug use that they were suffering from. We evaluated behavior implementation of essential care practices, assessment and management skills of mental health and drug use conditions. Thus, then we can say that brief intervention has involved goal setting to change behavior patterns, action support plans, and life skills to cope with the severity of mental health symptoms and alcohol and drug use. Finally, we can say that functional analysis, decisional balance, goal establishment, skill training, and follow-up resulted on 8 out of 10 participants successfully discharged from the brief scientific-based intervention, indicating high satisfaction with the quality of the services. The information technology system that we have been using helped to reduce the care gap for remote psychological service by addressing participants' mental health by risk level. The program enabled early detection of risk in Mexican community and interrupted the progression towards severity. The algorithms made easier to early detect and discriminate cases requiring specialized evidence-based intervention from those who just may require psychoeducation and community intervention alone. Then we suggest that public policies should consider planning cost-effective preventive intervention to address harmful use of alcohol and other drugs and improve mental health as a reduction gap strategy at the community. I want to thank to all the participants that were helping us to make this possible, because it's not just me, it's a lot of people that are working with us in this strategy. Thank you very much.
Silvia, these guys are making my task very easy today. They're sharp on time. Thank you. Last but not least, I have the pleasure of presenting my dear friend and colleague here, Andreas, Dr. Andreas Alexander Hein Willius. He's a hard name, but he's a good guy. Andreas Hein is a trained psychologist at the University of Chile with a master's degree in sociology from the Pontificia Universidad Católica de Chile, and has earned his PhD in evidence-based social intervention for the University of Oxford. He's passionate about applying data analytics and has recently undergone training in data science with a focus on data automation, machine learning, and big data. During his career, he has combined academic and applied research with development, implementation, and improvement of interventions aimed at vulnerable populations. He specializes in psychometrics, intervention research, design, implementation, and impact evaluation, and evaluation use. Dr. Hein has collaborated with think tanks, NGOs, governments, universities, and international organizations, focusing mainly on producing knowledge that promotes social change through the use of data and evidence. In recent years, he has served as manager of regional dissemination projects for the Colombo Plan and as a consultant for CICAD. In this context, he has led the development and adaptation of standardized professional training curricula in the treatment and prevention of substance use disorders. In this context, he was responsible of building and training an international team of regional prevention trainers, CICAD and Colombo Plan collaboration. He has led demand reduction training and technical assistance missions in Paraguay. We had him in our country. Brazil, Peru, Mexico. I'm sure many of people of the audience also know him for that. Colombia, Guatemala, Ecuador, the Dominican Republic, and Kenya. He currently collaborates with the Global Center for Credentialing and Certification, developing standards and exams for the accreditation of professional competencies in the area of drug demand reduction. In addition, he collaborates with the Cordia Foundation, Chile, as research led on monitoring, evaluation, and learning. As part of his efforts, he's in charge of a 5-year plan to assess the impact of Cordia's Train the Trainer model to expand computer science education throughout Chilean schools. Welcome, Andreas. The floor is yours.
That was long. Sorry about that. Okay. I would define myself as an unconventional academic because I've alternated in my roles between traditional academic research and as a faculty professor and fully blown management position in international organizations. So what I would like to do today with my 12 minutes is to invite you to think about the problems related to diffusion of evidence-based practice and interventions and explicit knowledge on how actually to implement them in a way that they work. So, at CICAT, there's a mechanism, so every few years governments are asked to self-report about what they do in several areas related to substance use treatment and prevention. And the last mem we revised, for example, we were able to track 278 prevention initiatives that are operating within Latin America and the Caribbean. 13% of those mention trademark programs, so programs that are these evidence-based programs we know, like multisystem therapy, SP, SPF 1014, or all kinds of unplugged or all kinds of programs like that. The most popular program, because it has been adapted to Latin America, is exactly Familias Fuertes, SPF 1014. But the question that remains when you think about actual diffusion of evidence practice in the region is this kind of information gives us very little understanding of what actually is happening. What is the coverage? What is the quality? What is the effectiveness of the kind of interventions you see? And the other issues, when you actually follow up on these 278 programs, sometimes some of them are no longer working or are very small, and sometimes government officials change and their new officials are not aware of other programs that are there. I've been government official actually answering these kind of surveys, and not usually very accurate or very informative sometimes. So a few years back in 2018, CICAT sponsored another study to make an actual tracking with the University of Miami of programs and initiatives that we could consider in a broad way as structured prevention programs in the region, not necessarily evidence-based, but we were able to track down and identify 77 programs in 29 countries that will conform to sort of a certain definition of evidence-based practice or prevention practice. The interesting fact about those is that about 2/3 of them were developed in-house in each country. So very few of them are actually like trademark programs, and it is, I would say, widely related to a wide range and sentiment in the region that we really want in Latin America to do our own work, because we sometimes feel that external programs either they're not adapted enough or sometimes explicitly don't like American work. I don't know why, but it happens. I can talk from experience. It happens in Chile. It happens in many places. So that there's this interest, the need, and there's been significant commitment and investment in many countries in developing their own work. Most of them have a universal focus, focused on people, about a third on families, mainly focused on skill development and attachment to pro-social peers or family attachment. Most of them are not easily accessible, even those that are trademarked. And one interesting case is Familias Fuertes. It was detected that it is no longer implemented as it was originally designed. There are variations across countries, so we can't really know if it is still as effective as it was designed and when it was intended. So, and the role of CICAT has been expanding on the idea of, well, how do we promote expansion of evidence-based practice in the region? And in certain workshops we've been doing, for example, here's a sample of 15 countries we've been working with. What kind of support needs do countries voice when we talk about the need to expand evidence-based prevention? Most of them, or many of them, ask for help to advocate prevention to authorities, mostly to be able to get funding. Many of them needs assessment or needs assessment. They require assistance on designing comprehensive policies and programs, training and program implementation, and many of them evaluation of their own developed in-house programs. So although the reality among countries varies greatly in terms of substance use, it is possible to say a few things. So one thing is we still have a lot of uncertainties about the actual scope and coverage of prevention programs in the region. We don't know nearly nothing about implementation quality and fidelity. and very, very few programs, about 10 or 50%, do have effectiveness or efficacy data that has been published and is widely accessible. So, and the other thing we can know is that we have a really low accessibility to different programs. And that is a key issue because sometimes programs that have been designed for certain contexts, either they have low scalability, they're difficult to implement for certain contexts. So sometimes we would like to have more variety, not only one prevention family program, hopefully 3 or 4 that have different structure, different session duration, different alternatives, so that actually countries can have a wider pool of programs where to choose that are actually adapted to the region. So the problem to be solved, this is a Chilean thing. We say that men can't chew and walk, chew gum and walk at the same time, mocking us that we can do 2 things at one time. But when we think about this problem, it seems that we need to. So the kind of requirements that we need to face to expand evidence-based prevention seem to be very, very wide, very different, and probably not one strategy will solve. In one country's top-down strategy may work, in others it may not. And that is because they're very, very different countries. Caribbean is very different to South America. Chile is very different from Argentina. And we need to think about having a strategy that is flexible enough to work through these issues. So, this is work in progress. We have been working on the idea of developing a regional hub for evidence-based prevention practices with a few components. So a hub is what it is. It's a node that seeks to facilitate exchange of knowledge, information, and resources and capabilities. Okay. Our key objectives are: we want to contribute to to increase the number of prevention programs and active implementation in the region that adhere to minimum quality standards, contribute to increasing the coverage of these programs, and contribute to increasing availability of different kinds of programs that target key risk factors that we could actually offer throughout the region. And one key component is here, we are detecting programs like the ones you're seeing here that they shouldn't struggle to be exported to other countries in the region, above all countries that have similar cultural backgrounds. We should have a structure to make this flow easier and not only dependent on the academics and the contacts they make. There should be a more concerted effort to do that. So what we're doing at this moment is CCAT always has been working on receiving demands from different governments and technical assistance, but we are now trying to structure this to respond in terms of having a pool of, I would say, regional mentors that can actually help us cover this wide range of needs that are emerging. CCAT, in its role, usually liaises with governments, raises assistance needs, do strategic planning, and organizes the work, seeks funding, and so on. But at the moment, we didn't have like an organized capacity to count with a force, I would say, of mentors that would help us tackle this wider range of needs that we're facing. And down are listed many of the needs that we're getting. So, for example, the things we would like to support countries is to help them piloting and adjustment of prevention initiatives, support them for effective implementation, support them in evaluation studies, and so on, monitoring, evaluation, and dissemination of results. So we're building this network now, and we're mimicking our experience when we actually built our regional trainers network. We have about 30 trainers in prevention that we've been using for several training initiatives across the region, mostly based on the UPC system. But to bring this together, I would like to highlight like 2 key components. One, we have done a revision and a new development of quality standards and an instrument for structured assessment of quality standards, now focused on prevention. There are some around, but we have revised it again, and we are in the midst of building a learning community, because one of the key issues with mentors, you can hire experts. Expert knowledge is very rare, but expert knowledge needs to be diffused. Other mentors need to learn from that, need to train on that, and need to be able to implement this tacit knowledge and convert it into explicit knowledge for implementation. Because implementation is hard. We all would like to have programs do and governments do randomized trials, but the fact is a regular or normal organization will take up to 3 years just to implement and use pre-post test data. It's a fact of life. Perhaps some shorter, perhaps some longer, but it will take time because we need to focus on structures and organizations too. So, just briefly, 1.5 minutes left, I'm conscious of that. We have revised this prevention initiative and quality standards. We have devised 15 standards. And this time we also have developed a structured instrument to assist mentors to work with the countries. And we have divided each standard with a criterion that are divided between 3 levels. 1, quality standards related to a specific initiative, to the implementing organization, how organizations need to work on quality implementation, and standards related to context and systems. So depending if the government is asking more about context kind of interventions, we can work on quality standards for system level. If it's an organization, we will work in things like performance assessment and how to introduce and integrate this. 1 minute?
Less than 1 minute. Yeah.
Okay.
Thank you.
I'm going. And the initiative, there are many initiatives going around that claim to be evidence-based, and government should have tools to really assess if they meet their minimum requirements for having manuals, implementation manuals and procedures to actually make them effective and easy to introduce into usual practice. Here's an example. If you really want to look a bit more about this, I will take my last minute, my last 30 seconds. Mentor profile. We're recruiting now mentors. We have recruited about 30 mentors that have specialized knowledge in the region. They are experts in prevention science and implementation of specific trademark interventions like Unplugged and Familias Fuertes and others, or are experienced in implementation of substance use prevention programs at a government level, and monitoring and evaluation experts. So we're building a very wide pool, and we aim for them to recruited to lead specific implementation projects, but we also want to recruit young mentors that are promising in their fields to work with these old mentors and learn the trade in practice. With time, we want them all to take certifications in the GCCC or now ICDDR system and accredit that they're actually competent in prevention and evidence-based prevention and prevention science, so that they can lead with example and show to other countries how to conduct this intervention. So, my last comment, we also engage them in competency gap analysis. So we do a competency assessment, we have a competency framework, and we will do focused training to put them onto speed on leveling their competencies where they feel that they still need to develop a few things to engage in the complex world of implementation of evidence-based interventions. And that's it.
Thank you. Thank you very much, three presenters. Great ideas and great things come to my mind, and I'm sure they come to your mind as well while we're listening to these 3 guys. But I felt like I needed to listen to them more, right? They have much more to say, and we have such a short time. I'm sorry, I'm the bad girl of this table. But maybe we can go, this is now the time for questions and answers, and we can kindly make the questions. There is a microphone, right? This guy is going to help us with the microphone for the people wanted to raise a question. And then we can hear a little bit more from our presenters.
Good morning. Thank you very much for all the presentations. My question is for Dr. Silvia Morales. If you could tell us a little bit more about the experience with training the promoters, and maybe what type of the characteristic of these promoters, the amount of efforts to train them to achieve those level of competencies that you describe.
Yes, thank you for the question, because they are mainly women. We have men, but they are at the consulates of the United States, and they have been working with us in brief counseling. They learn how to screen some symptoms and behaviors that are risky behaviors of Mexicans. And then we have this technological app that helps us to register when they accept to take care and have psychological intervention. Our promoters are are not psychologists, are not doctors, physicians. They are just from the community, but we call them gatekeepers because they know very well to the community, and they learn how to be near to them and ask them about how they are feeling. And they have this network also to help them not just to get psychological care, but to get legal advisors and economical ways to live in the community. Then they have this special profile that helps us a lot with mental health and drug and alcohol risks. I hope I was clear, because I told them that they are called for us. They are very great people, and we call them the gatekeepers.
Thank you, Silvia. That's a great name, gatekeepers.
Yeah.
Right there.
Hello, good morning. Thank you very much. This is a question specifically for Andreas from Chile. Thank you very much for the lecture. I found very interesting. Also the scoping review, I would be very interesting to read it throughout. The thing while you were presenting, I was thinking about this hub and this hub that you create or you have. It's very interesting, and from my background, so I coordinate the training of trainers in Unplugged and also the cultural adaptation of that program. And what I have seen and have found until now from experience is the thing that I was thinking about this hub. Why should this be first like substance use prevention centered? If you look at the email inbox of a school principal, this guy, this lady, she needs to work on eating disorders, other mental health issues, a whole bunch of thematics. And then secondly, I was also thinking this hub, although it's very interesting and very necessary also, how should we position this? Should there be a hub for education or like infiltrated into existing educational support systems? These are more or less the things that I was talking about, and I don't know, you surely have thought about with your team as well. Thank you.
Thank you. Yeah, I've been training myself for a number of years now, so I've been facing this, and I'm about to start, for example, a program in Colombia. While we're thinking, it took me a year to recruit 65 teachers from 30 schools for a specific program, to really make sure, for example, that they understand what they're getting into. So what we are doing as Hein commitment and what they need to compromise. And that is a part of implementation and evidence-based prevention that rarely gets in the books. I would say lately we only see this in implementation science because it's hugely costly in time, and there you can make very critical mistakes that will make your program not work. For example, many organizations sometimes are very obsessed with numbers, so they go over numbers, they don't explain very well, so they do the short processes, and then you have higher dropout levels after that. So having said that, and having that in mind, and also an experience because on actual implementation and monitoring evaluation and so on, first I would say is to be mindful and to understand your context, and that's why the strategy is, I would say, more loose, because these countries, they have different preferences, and you have to work with those preferences. And then we have been facing criticism, for example, that we should only promote like trademark interventions, they're ready, they should take it and roll it in. But if you face a country that really dislikes, and it can be very irrational, but if they dislike American interventions and you push it forward, it just probably won't stick. So if they have been investing in a program by themselves, even if it is more costly at the beginning, why don't you support them to get up to the standard so it will stick probably? It may take longer, but then you have to shift your thinking to it's a marathon, not a sprint. Long-term thinking, 10, 15 years in advance, so what you do today, if you do it right, probably will pay off later. Because this fit between intervention and organization is really, really important. Sometimes there are organizations that dislike the philosophy. Sometimes there are organizations that prefer Familias Fuertes instead of Triple P, because Triple P uses more reinforcement and Familias Fuertes builds more relationships. And I think countries should have the possibility to select. So what evidence tells us about other kinds of choices, as you have more choices, it's more probable that you will have more adherence because you can find the specific program that will fit your need instead of trying to spend so much time in building capacity. Capacity will still be a factor. But that's why I think availability should be a key issue, and we think CCAT has a privileged role because it has contact with every drug commission in the region to support the cost of adaptation, at least for countries that are more or less similar. For example, for the Caribbean region that speak English, more or less we can do perhaps one adaptation study, even though we need to follow up later. But then you could have a program available for 13 countries at once. That's the kind of reasoning we're going with now. I could talk a lot about this one.
Thank you, Andreas. Winston.
Can you hear me? Yeah. Hi, just a comment for Andreas. So using evidence-based program is one thing. Without the ability to track persons, youngsters who've been exposed to these programs, and it's very difficult to comment on efficacy. I just wondered if anywhere in your view you're looking at cohort studies. For example, a birth cohort would be ideal, but even a high school cohort study would really be. I have heard you mention, I'm sure knowing you, you'll probably have this covered, but I just wondered, I'm not aware of any in the Caribbean, maybe Latin America, I'm not sure. I'm from Jamaica. Thank you.
You mean if I'm aware of programs with cohort studies? Yeah, there are. But I think I would say the point of the presentation is slightly different. In terms of when we use evidence-based intervention and we diffuse models that have been 30 years in the making, and I will discuss like early years, incredible years and so on, they're 30, 35 years in the making. But we have been accused in Latin America, a friend of mine is academic, of being consumers of knowledge, of foreign, and to a point I would say that's true. And many feel that we should need to develop our own kind of interventions. I think any of both ways could be fine. But I think the point I wanted to raise is many evidence-based interventions started just like that. A clinician doing a practice and then following the steps of intervention development. Qualitative testing, then efficacy testing, and theory, revision, and so on, until you go to the randomized trial. So if we wait for the perfect conditions, they will never be there. But if we start now, and we think this is a development that will take a time, then time will pass, but you will have gained knowledge and diffuse it. So I'm not saying this is the only way. I think today still it's easier and cheaper to use a trademark program. But you need to consider your context. So if you face opposition, philosophical or for whatever reason it is, you can try different things, but I think you need to follow the path of least resistance. The thing at the end of the day is that any program you implement needs to conform to high-level standards, no matter where you are. Actually, we had a discussion 3 weeks ago with Scott in Jamaica. He was very keen, a mutual acquaintance. He was very keen, we want to do this. He said, fine, but you need to think that you need to meet the high-level standards that Americans use and Europeans use to validate their programs. You can't do it in any other way because these are the international standards. If you're up with that, then let's go. And you can combine it with others. Because at the end of the day, the issue is expansion, right? So you need to roll out programs to as many people as you can. And in the current conditions, we're seeing very limited roll-off of its big practice, in the region at least.
Thank you. Yes, and then Sergio.
Good morning. I have a couple of questions. I would like to address one question to Professor Silvia Morales. I am curious about the use of algorithms that you mentioned, and I would appreciate if you could comment a bit more about that. And let me state the second question. Yes.
Answer the first one, and then you can.
Okay. Sure.
I forgot.
Sure. Okay.
Yes. Well, the algorithms were based on the MH-GAP, the PAHO recommendation about how to screen these behaviors, risk behaviors, and how to take these decisions when you need to give primary care or community care or maybe specialized care. We have been programming that in the app. The people start sharing with us the symptoms. After that, they receive feedback about the symptoms they were sharing with us. And in the second place, they can ask for help. And then we call them and start with the brief intervention by Zoom or Meet or any other kind of technological system. Yeah.
And the second question, I would like to address it to Professor Fernando Salazar Silva, and about the school-based prevention programs, which is a work that we do very often. I work in a prevention center here in Thessaloniki, and we work together with schools, with teachers very often. And sometimes it seems that the more sophisticated the prevention programs become, the less easy it is for schools to collaborate. Although in the long run it makes, of course, it improves the climate, the school climate, the relationships, they are effective. But sometimes we find it difficult to find people in the schools to implement the programs. Yes, and of course there are also other. We sometimes also encourage them to make a shorter version of some programs, so as to gain that at least they don't get interrupted. Well, could you comment perhaps how you managed to earn the collaboration or to overcome such difficulties? Thank you.
Thank you.
Those are key questions. The first, if I understood the three questions, the first is the persuasion of the community, of the school community. One of the first things that we have to do is to go to the community and highlight the problem, because the problem is different in the mind of the school teacher, because it's learning of the kids. And for the father, it's a different problem, raising the kids. And the school, sometimes using the school children is not the real problem for them. So we have to show the problem, persuade the school community to initiate prevention. And after you do that, the second one that is linked to the sustainability of the intervention is to create and build the prevention teams. And the prevention teams, I didn't explain how are they conformed. That they are, in part, the principal, the school teacher, the student by itself, the parents, and other stakeholders. And they are going to conduct a needs assessment, they are going to plan, they are going to implement, they are going to monitor the different aspects of the intervention. That looks quite complicated, but it's not, because the other thing is how to integrate all of these areas into the school curriculum. Let's say the school policy is part of internal regulations. That is also part of the general mandatory things. The school climate has its own area in the schools. So the school climate for prevention is the same like the school is doing currently. And finally, according to the school curriculum, we can have different areas in which we can put the school prevention curricula that are 12 or 15 sessions that doesn't have to go in one area. They can go in different areas, maybe mentoring, maybe planification of school activities, maybe leisure of kids. They can put in different areas. But that needs a very strong planification all together with the school. Without invading the school with a program, we have to transfer all the intervention to the school principal and the school teacher and to the parents, and make active to the school children. That worked pretty well, and it's not difficult. I apologize if I give you a different idea.
Thank you, Fernando. I think we have Sergio on the list, and then I wrote my name too because I have a question, just so you know. Right here. Thank you.
Thank you. My name is Sergio Chacon. I'm from Chile. Hi to everyone. What an honor to hear you, the three of you this morning. I have a question for my friend Fernando Salazar. I would love to hear your perspective on what is the contribution of implementation science to school-based prevention.
Two things that I think are the key issues: persuasion and building teams. You need people that is really eager to implement prevention, and after that, the implementation science is saying, yes, let's go in the way that we used to do everything. Needs assessment and resource assessment. So you can link the need of the school with the resources that they have, that are different kind of resources. Human resources, the school curricula, the school hours, the budget that is already in the salary of the school teachers, and that is a very serious issue. Also, after that, the planning of that is in the cycle of implementation has to be linked to the different areas of the work of the school teachers. And you will find many empty hours or free hours for planification, whatever, but you can use those hours. And that is important to know that thing, because the school teachers are evaluated day by day with some rubrics that are pretty close to the interventions. So they can be doing the same thing for prevention and for their own job. And after that, monitoring and evaluation is part of the intervention, because they can adjust and even adapt the intervention to the school curriculum. And finally, evaluation. We have to communicate to the whole community what are the results. With that thing, let me say, we finished our intervention, our project in the 2021, and until now we have schools that are working alone, and they are still reporting in our WhatsApp group, day by day. So it's because the structure for prevention was clear. And also those structures, everything has to be recorded and recognized formally by the school system in different levels.
Thank you, Fernando. Now I'm on the list of questions, but he already answered my question. It was very similar to what Sergio had to say, because we're hearing repeatedly in the three interventions that we really need a prevention specialist to put their to set the goals and to prepare the structure for the prevention efforts to work. Because otherwise we have the elements and it's not that complex as Fernando has said, but when you see it all of a sudden, or when a school administrator or a teacher looks at what they have to do, first thing they say is like, oh, this is more work for me. Good for you that you want to do prevention, but this is on me. And so it is our role as prevention specialists to do all this awareness that Fernando was talking about, and showing them that actually what you're trying to do by convincing or aware that they have to do prevention is you're making their work easier, because they will have less problems with time. It's just always a thing on commenting on prevention, that the results are not seen immediately. And we on the culture, the characteristic of this area, globally, I think, is that we want to see things immediately. We're so much in the move of what's the result, what's the impact. And besides that, many organizations, and school being one of them, unfortunately, want to see numbers. How many teachers did you train? How many students were in your classes? What's the percentage of decreasing consumption or initiating consumption? So that's okay, but we need time and knowledge and a lot of passion as well. Any other questions or? Yes, please.
Thank you very much. I'm a consultant from a therapeutic community. We are in a Kids and the Drugs. It's a cause where we go to schools and we do prevention with a card from Bulgaria. What is the most inspiring about the school class where the drugs are used in the same class? Because most of the kids, we ask about responsibility, we ask about the freedom. What is the most touching things when we touch these kids to not get in the drug areas?
Yeah. If I understood the question, is if you go to the school and the kids are or even using in the school?
Using drugs, yes.
Right. And what we can do with a school intervention is, let's say I'm redundant with this. You organize the school with the different actors and they agree to put a school policy. And the school policy communicates the principles and the values of the school,
yes,
but with the agreement of everybody. And also, that may fall in an empty space, and the kids still keep going. So, all together with the school policy must be developed as a group of people that is going to enforce that policy, and also that positive answers under the school system to the infractors of that policy, of the prevention policy. It's education, it's just only education, it's not punishment. And you have to record that and start communicating that kind of events to the whole community, so you can start normalizing what is the expectation of the school for all the community. It's pretty difficult to deal with kids that are taking substances at the school, because that is maybe, yes, people that is not taking experimentally. They could be in the edge of a substance use transfer. Yes, substance use disorder. So all the system also must have a way to deliver those kids to counseling or treatment, and then they have to record when the kid went to that counseling or treatment and go back to the school under the rules of the school.
Thank you very much.
If I may add, usually countries have what we call a protocol. The ministries of education have protocols and rules and regulations and policies that are to be applied in those cases. Besides the school regulations, usually governments have some kind of a protocol or a regulation on what to do, what steps to make in that case. What's that?
Court. They organize discuss kids and the drugs. And we are from a therapeutic community.
I see.
We, yes, it's,
Yeah.
thank you.
Thank you. Okay.
Hello. I'm from the Philippines, working in an outpatient drug recovery clinic, voluntary. And recently, as part of our advocacy, we have been doing some talks among senior high school students. And one thing that we've learned was that drugs can be accessed online. And we've been getting questions from high schoolers. So I'm just wondering, can you share some of your insights regarding this? Because we were having a bit of a debate in our clinic on how to approach this.
Yeah, one of the things that we have to be aware is that the school intervention is just one component. And we need to start developing the community prevention systems. That is a multi-component approach in which one of the things is just the regulation of the social media or the internet and so on. Because just walk around the venue and you will see some displays in which you can buy vapors with cannabis, and no one is controlling that. And I couldn't walk around that area to see if our school is 200 meters at least far from that point of selling vapors. So we have to start working with many different interventions. Just one alone is good for prevention of initiation, but when you are looking to kids that need some selective intervention or indicated intervention, you need a system.
A system that will support prevention. Yeah. Any other insights or comments or questions? Yes, ma'am.
This is for Dr. Silvia. You alluded to intervention barriers that you encountered when you implemented. In your presentation, there were barriers. I think you said 2 out of 10 people. If you could just expand on what those barriers were, just a little bit information, please.
Can you repeat and simplify your question, maybe, please?
Could you repeat the question because I didn't get the...
So in your, is it a bit closer? Is this better? Intervention barriers, you spoke about that in your presentation. If you could just give us, or me at least, some more detail.
Yes, I was talking more about the technological barriers because we have been, I think, this better opportunity to give the treatment to people because they were asking the promoter, as I was telling, they did a great job sensibilizing the participants and telling what are the advantages of having treatment. But sometimes they changed their phones and we were trying to reach them and we we haven't this opportunity to be with them. This happened to every 2 out of 10 participants. Then we have been working now very close with the promoters, and they just not take their phones. Now they are taking their emails, and they have these other ways to help them with the barriers and helping to get better results about that. We're still having problems because sometimes they don't have these technological ways to work with us, but now we think in the last statistics we have just 1 out of 10. We have to keep trying, but I think that's the main barrier we have been facing. Thank you very much.
Thank you, Silvia. We have 10 minutes. Yeah, we know we are what is interfering with your lunch time, so but we still have 10 good minutes so we could discuss a little bit more. If you have any questions, or if any of the presenters would like to make a final comment, maybe in 1-2 minutes. Any? No? Yes, there's a question.
Good morning for everyone. I'm Deborah. I'm from Brazil. We are implementing some programs nationwide, and now we are discussing monitoring. And you talk a lot about quality and fidelity, and this is an issue. This is a challenge, I can say, because we have many instruments, and in different levels, the teacher, the student, the person who is responsible for monitoring at the territory, and the secretary. It's a multi-level structure, so we have to have a lot of instruments, and we are really worried about that. Like in Brazil, some schools we don't have like tablets for the students to answer. So if we give them papers, we would have to transcript, I don't know, to put online, and who would do that? You know, it's a lot of questions that we ask ourselves. We're about to begin this national level implementation. So I would like to have some thoughts about this, about considering your experience. Thank you.
Thank you. Yeah,
Thanks, Deborah. You did a right question. I think that there are people that is in the middle of the question. You did raise your hand, Johan. Johan is unplugged trainer. And in Brazil, Unplugged had 2 grants. One that was over-adapted and didn't work. And the second round was when they keep going with the fidelity to the program and not too much adaptation. And that is showing positive results. So the only bad thing about that is that those were part of 2 RCTs, 2 studies. And in RCTs, we have the budget for the people that is going to do the monitoring and evaluation. And usually, that is a part of the budget that nobody wants to take care because it's costly, but it's the guarantee for successful results. So my recommendation, my pledge, whatever is this, is if you are going to ask money to the government or the founder, just put in the budget the monitoring and evaluation. If not, all the things may fail. Right? Thank you.
And I just want to include that maybe we have been working with these instruments to make it easier with less questions, with enough questions to evaluate, for example, mental health risk. No? For example, you know that for depression we have this patient health questionnaire of 2 questions, then it's shorter questionnaires. But also I think the permanent products from the skills that people are showing are another way to not to just evaluate with a lot of instruments, but with the results of the skills that community are learning. Not just videos or audios about the skill, but the results from the implementation of the skill. If they are doing maybe, sometimes they are exercising, they are doing a good nutrition, and all the results about the skills are another way of assessing or evaluating the results of the prevention programs. I think we have to take care about that. Thank you.
Thank you, Silvia. Andrea?
I think, piggybacking on Fernando, you need to differentiate the data you collect when you're in a study, like for a randomized trial, from the data you need for normal operation of a program. And we have asked that the whole time in Chile too, so my first question is who designed the monitoring and evaluation system and what specific uses you have for the data you're collecting. When you look at the first one, there's usually a sociologist involved, and they like to collect a lot of data for fancy regression models. But the second question is the critical one. What actual use are you giving to what specific type of data? And when you do that second one, you usually are able to trim a lot of unnecessary data. Usually you start with more questions and indicators that you need, and when you test them, many of them don't work, are not useful, they don't have the variance you need, they don't tell you anything relevant. So usually in evidence-based practice, it is recommended that you focus on 3 or 4 key indicators, and in monitoring, you need to be very careful on what specific things you do. And the key question is always, what do I use the data for? And we had that in Chile, sometimes we've printed out the spreadsheets. And there was a famous example where the spreadsheet was so long it could turn a whole room. And then the implementer spends half of his time putting in data that nobody uses, or you do fancy regression models that won't work because you overspecify them. Whereas you can actually focus on very, very specific information. And my best advice there, use information that is also useful for the implementer. So usually when you work in programs where you do, for example, screening, and the implementer needs the data to make decisions, it will increase the possibility that they will actually use it, because they need to use it, and this data is simultaneously useful for the implementer and for top-level decision making. Would be my advice.
Thank you, Andreas. Well, this was amazing. We covered so much in the time that we have. I feel that we used very wisely our time. So thank you all for being here. Thank you to our presenters. And we'll see you around. Let's have lunch.